Okay, welcome to video 2 of this lesson on potassium and calcium and phosphate handling. We're going to talk about potassium regulation in this video. So, as you can see, here's our transport mechanism, which we covered in the last video. There are 4 potential ways that you can change potassium secretion across this epithelial layer. Okay? Number 1, you can shut these potassium channels in the apical membrane down. So now there's no way for the potassium to get across the apical membrane, and that's where these basolateral channels become important, because what's taken in can actually escape back out into the interstitium through this channel when this potassium channel is closed. So that's one thing you can do to decrease secretion. Number 2, you can close or eliminate the sodium channels here in the apical membrane. So what that does is it causes sodium to decrease in the cell, because you're no longer reabsorbing sodium here in the principal cell. The sodium concentration drops. When that happens, you slow this ATPase down. When you slow the ATPase down, you slow the potassium transport into the cell down. So that's another way that you can decrease potassium secretion indirectly, by shutting down this sodium transport here, this sodium reabsorption. All right? You can also, through a simple drop in extracellular potassium, slow this ATPase down. So low potassium here means less transport here and lower potassium here, and that will decrease potassium secretion. And then finally, if you increase tubular potassium here, you decrease the concentration gradient from inside to outside by raising the potassium here. That will slow reabsorption. That will slow secretion down, because not as much potassium will be diffusing through this channel into the tubule. Okay? And you should note at this point that by simply decreasing tubular flow, you can allow potassium to accumulate locally around this channel, and when potassium builds here, you will decrease the potassium flow through this channel. So simply by decreasing tubular flow, you can cause tubular potassium to increase, to accumulate here, and that will slow the secretion down. And that turns out to be fairly significant. All right? So those are 4 potential ways you can change this. Let's think about how aldosterone works now. Aldosterone, as you know, controls the sodium channels here. You get more sodium channels under the influence of aldosterone, and that will increase sodium reabsorption. It turns out that aldosterone also opens up these potassium channels, okay? So your potassium secretion is under the control of aldosterone. So let's see how this works. Let's say we have an increase in potassium intake in our diet. That increases our plasma potassium concentration, and that causes aldosterone to be secreted. So in addition to changes in sodium, in addition to angiotensin II and the other mechanisms that we've talked about for changing aldosterone, potassium also controls aldosterone secretion as well. And it does this because when you increase the potassium concentration in the plasma, as you know, you depolarize the membrane in the cells. When you depolarize the membrane of the cells in the adrenal cortex, it stimulates them to release aldosterone. So aldosterone can be released in response to an increase in potassium. Now bear in mind, that's not the major controller, but it is a controller, okay? So that you get an increase in plasma aldosterone, and that aldosterone, by opening up these potassium channels, can cause an increase in potassium secretion, okay? And you should also remember that aldosterone stimulates the sodium-potassium ATPase, and that can increase transport of potassium into the cell, and that will increase secretion as well. So our aldosterone is causing an increased potassium secretion. Now you should also note that if you have a high potassium in the plasma and in the interstitial space, that will also increase the sodium-potassium ATPase activity because you've increased the concentration of the substrate. So that also will cause an increase in secretion all on its own, even without aldosterone, simply by increasing transport across this membrane. All right? So, so you get an increase in potassium secretion due to that. All right? So that's how this can ordinarily work with our aldosterone control. Now, another major controlling mechanism is through tubular flow. So here on this graph, we have distal tubular flow in the lumen of the nephron. And here we have potassium secretion rate. And you will notice that as the tubular flow goes up, the secretion rate goes up. And that's because when you increase tubular flow rate, you're washing away this potassium. And that causes the gradient for potassium to be transported from inside to outside through this channel to be even greater. And so you increase the potassium secretion by increasing the tubular flow, okay? So if we have a low flow rate, you will notice that secretion is down here. And that is because this potassium is accumulating around the channels. You decrease that concentration gradient. With the high tubular flow rate, as I said just a minute ago, now you're washing that potassium away, you're increasing that concentration gradient, and the potassium, more potassium will actually go through the channel from high concentration to low concentration, okay? And then finally, you should notice that a high tubular flow rate will deliver more sodium to this channel, so you'll actually increase sodium transport across the apical membrane through the sodium channel in the principal cells. That will increase sodium concentration in the cell. That will increase the sodium-potassium ATPase activity because you've increased the substrate here. That will increase potassium transport into the cell and out through this potassium channel in the apical membrane. So you can get increased secretion with increased sodium reabsorption as well, all right? And that will take place with high tubular flow. All right? All right. So, you might think, oh my gosh, well now aldosterone is controlling two things. It's controlling sodium and it's controlling potassium. So don't those two things conflict? Can that cause a problem? Well, let's think about it, all right? Let's say you have a patient. A patient's got a high sodium diet. There's an increase in the plasma sodium. There's an increase in blood volume because of that, because reabsorption, or because high sodium in the plasma means higher osmolarity, and you reabsorb more water, and you have a high blood pressure. Okay, all right. So this is a high blood pressure patient with a high blood volume. All right. Let's think about what happens because we have this situation going on. You actually get a decrease in aldosterone, okay? Because what you want to do is you want to decrease sodium reabsorption. You've got a high sodium diet, high sodium in the plasma. You want to decrease sodium reabsorption. You want to excrete more, so you drop your aldosterone, okay? Well, if you drop your aldosterone, you decrease sodium reabsorption. That's what you want, but you will also decrease potassium secretion because these channels are shut down, okay? So this is a side effect, and you might go, uh-oh, well, that's a problem. Well, let's think about it. If you drop aldosterone and you increase the sodium here, you are going to increase tubular flow. And you're also going to have, even more important than that, you've got an increased tubular flow because you have high blood pressure and high blood volume. You've got more filtration going on. So you've got an increase in tubular flow here due to the high blood pressure, okay? Increased tubular flow washes away potassium, increases the potassium gradient. That increases potassium secretion across that apical membrane. So you have aldosterone decreasing secretion by shutting this channel down, but you've also got an increase in potassium secretion through the channels that are left because you're washing this potassium away. And so what you get is the two canceling each other out, and the potassium, in fact, doesn't change all that much, okay? So this is a situation where, yeah, aldosterone's under the control, is controlling both, but in the end, they don't conflict, okay? Certainly not as much as you might think, okay? So, having talked about tubular flow, we may want to talk about diuretics, which of course do increase tubular flow. So let's think about this. Usually, now I'm not going to teach in detail about diuretics. I'm going to leave that to the pharmacologists. But I think in context here, it's appropriate to just quickly talk about this. Usually diuretics increase sodium excretion, right? You leave more sodium in the tubular lumen, water, less water is reabsorbed, and you get a high urine output, okay? And that's usually how this works. So if we look at the diuretics that act upstream of the collecting duct, upstream of that cortical collecting duct in particular, these are going to increase potassium excretion as a side effect because they are going to increase tubular flow by whatever mechanism, because you're leaving more water in the tubule, and that's the whole idea. You want the patient to urinate more. Okay, so you get this increase in tubular flow, that leads to an increase in potassium excretion. That can cause a problem, okay? On the other hand, diuretics that act at the cortical collecting duct, at this distal nephron, okay? These are called potassium-sparing diuretics because upstream of this distal nephron area, you aren't causing this big increase in flow. Okay, so you aren't causing extra potassium to be secreted when your diuretic is actually acting at the collecting duct. Okay, basically at the principal cell where aldosterone's acting. By the way, as we'll see in a moment. Okay, so these are called potassium-sparing diuretics because they don't increase potassium secretion. Okay, not like these do. And note the loop diuretics are in this potassium wasting category, okay? You're going to use those a lot. So let's say you have a heart failure patient, okay? That patient is increasing his or her aldosterone in an effort to retain fluid, so that to increase the preload and increase the cardiac output back toward normal, right? So we have an increase in sodium reabsorption and an increase in potassium secretion in response to that aldosterone, and this causes you to retain water, which will help get the plasma water up, and that will increase your preload, right? So if you increase your preload too much, as you guys know now, you accumulate fluid in the tissues, and particularly when that happens in the lung, that's a very bad thing. So you may give a diuretic to treat this heart failure patient, okay? And sure enough, the diuretic will reduce the sodium reabsorption, and the problem, and that will cause you to urinate out your fluid. The problem is that diuretic can increase potassium secretion by increasing tubular lumen flow. And if you increase tubular lumen flow and you increase potassium secretion here, you add that onto what the aldosterone is doing already, and now you get a big loss of potassium, and that can be a problem, okay? So this is a problematic side effect of some diuretics, particularly those that act upstream of the collecting duct, or of the distal nephron. Now, a potassium-sparing diuretic, those that act at the principal cell, first of all, one way or another, because they're acting at the principal cell, they're going to decrease the aldosterone-driven sodium reabsorption and the aldosterone-driven potassium secretion, okay? Because they're messing with the mechanism right at the principal cell, right where the aldosterone is working. So one way or another, directly or indirectly, it's going to decrease the effect of the aldosterone. And at the same time, you don't have this increase in upstream tubular flow that's causing potassium to be washed away. So you don't have this big increase in potassium secretion either. So the net effect is you don't get this big potassium secretion, and you still get the reduction in sodium reabsorption and the diuretic effect with the potassium-sparing diuretics. So you might ask, why not just use potassium-sparing diuretics all the time? Why use a loop diuretic at all? Well, the problem is that these aren't as effective at causing a diuresis as some of the others like Lasix. So a lot of the time what you'll find is you'll give a combination. You give the loop diuretic to get a nice diuresis going, and you'll give the potassium-sparing diuretic to kind of decrease the effects on this potassium secretion and make them less severe, okay? And again, the pharmacologist will cover that, but this is sort of the physiology behind it, the mechanistics. All right, so that's it for control of potassium secretion and urination, excretion. The last video will cover calcium and phosphate regulation by the nephron. Thank you for your time.